Welcome to the IHEP webinar titled Health Security Unbound. My name is Nelson Lee, Director of the Institute of Health Emergencies and Pandemics, IHEP, formerly IFB. Our institute is an interdisciplinary network of researchers and experts who strive to transform the future of public health emergencies. This research, using an all-hazards approach, and through cross-discipline collaboration, building capacity and driving actions to prepare for future health crises. Before we begin, I wish to acknowledge this land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and we're grateful to have the opportunity to work on this land. Today, we're going to discuss health security and what does that mean to public health and healthcare professionals, governments, and the society in the post-COVID pandemic world. It is certainly a topic of great interest, and I'm pleased to announce that we have over 150 individuals from various disciplines and sectors attending this webinar. So Ted, our Associate Director, maybe I should turn over to you to talk about a few housekeeping items.
Yep, just a few things. So if you require captions, there is a captions button at the bottom. Just note they're auto-generated, so they may not be perfect. And if you want to submit any questions throughout the webinar, use the Q&A feature. We'll get to any of the questions during the panel discussion after Joy's presentation. And this webinar is being recorded and we'll make it available at a later date.
Thanks, Ted. So let me introduce our speaker. Our speaker today is Professor Joy Fitzgibbon, a political scientist who research explores solutions to governance dilemmas in pandemic control and international security. As a scholar of international relations, she assesses the efficacy of policies shaped by global health networks, international institutions, and national public health and security agencies. Her current research examines the consultation between human rights and security and intelligence interests in defining pandemic prevention and response. In addition to a faculty position at the Trinity College at the University of Toronto, she is also a senior fellow at the Bill Graham Center for Contemporary International History. So, Joy, we are really excited to hear you talk about health security. I'll turn over to you.
Oh, thank you so much, Nelson. And thank you to you and Ted for the great honor of speaking today. And it's just such a pleasure to be here. I always enjoy the Institute's programming, and it's such a privilege to be part of what you're doing. I also want to thank in advance David Fisman and Victoria Haldane for so graciously being willing to comment today and share their insights. I admire them both so much in the work that they do, and I'm very much looking forward to our conversation after. So I'm just going to share my screen here, and everything should go well. Let's just pop it up. There we go. And let's just see. Can you now see my screen? I trust that that's good. So when I was asked to share with you today, I was kind of excited about this, in part because in my own journey, I've sat in a number of different spaces where I've seen the term health security used quite differently. And so while I'm loath to start a talk by, talking about concepts, I do think it's actually important here because we often use health security in quite different ways depending on where we sit. And also there are people, of course, that sort of work at the intersection of all of these different approaches to health security. So I thought that it would be profitable to talk about that today and to really highlight within different approaches some of the important, maybe the more prescient challenges that we face under each one of these sort of areas of health security. And then I'll go on to talk a little bit about the challenges that we may be facing here in addressing some of these very interconnected issues, actually. And I would say just this, that my punchline is that health security, each one of these approaches raise important issues that need to be addressed, and that we can learn from each approach. But we need to be intentional about how we're using them. So, you know, it is a diverse terrain, and I'm also going to talk a little bit about some of the critics of health security and why some people would prefer we not use a term health security before suggesting how we could respond to their concerns. So these diverse frameworks that we have, you know, describe different aspects of health and security risks. And it's important, I think, to be mindful about how we're using the term, in part because they can cause competing approaches to manage different threats. They can give legitimacy to some voices at the table over others, and they can shape the distribution of resources. So this is not a theoretical conversation. It is, in fact, a very pragmatic and important discussion. So the first approach, when I look at a lot of the practice of the literature on this, really is what probably a lot of us here today think of, a public health approach. And, you know, no surprise to most people here, but it's going to focus on population-based pandemic prevention, health system readiness, and capacity for managing crises, and also the structure of the system, you know, the way authority is distributed and responsibility, the possibility that that could shape the quality of the response. A couple of assessments recently from a sort of public health perspective. First in Canada is some work authored by Adrian Levy. It was something done at the Center for International Governance Innovation, and it was part of a larger project of reimagining Canada's national security strategy. And as part of that, there was a stream that dealt with pandemic response post, you know, the height of the COVID pandemic. And what Levy found was that Canadians' response at first was quite good, but then it became quite disjointed and inconsistent. We kind of didn't finish the job, to put it bluntly. And they, you know, the committee kind of attributed the federal structure of our healthcare system of having an important role here. And as a result, they proposed a biosecurity strategy that paid attention to those relationships in really thoughtful ways, looked at how we collaborate between diverse stakeholders, how we can become more transparent in our communications, support global partnerships, and focus on the social determinants of health. Coming out of the pandemic, another public health approach to health security really is the Independent Panel on Pandemic Preparedness and Response. Many of you, I'm sure, know this material well. But they identified, of course, a series of problems, including lack of preparation, underfunding, slow surveillance and alert systems, not, you know, applying the precautionary principle, getting out ahead, assuming the worst case scenario. And that was, you know, also sort of characterized by a kind of slow lack of urgent response, you know, not having the resources behind this, both in terms of supplies and funding, not prepared for a long crisis. You know, quite often we're used to something, you know, a kind of quick blip is one thing, but a longer crisis becomes a challenge. And then, of course, the mention of vaccine nationalism. So they argue for stronger leadership and better coordination at the global level, to invest now in preparedness, which probably a lot of people around the room would agree with, and strengthen our surveillance and alert system, including giving authority to WHO. Canada as well missed the ball. I say this respectfully on this, but we kind of needed to return to some of the things that we've done well. And then create a pre-negotiated platform for things like vaccines, diagnostics, therapeutics, et cetera, and then have that backed by really strong financial resources for rapid crisis response. The second approach is a national security approach. And this area is really, it is a multifaceted approach, but it's concerned with the security of the state. So, you know, deliberate biological attacks is one area, but cybersecurity attacks fall into this, particularly that involve public health related matters, foreign direct interference that undermine the social contract, and that, you know, challenge confidence in our governments, the sort of toxic disinformation space, and the intervention in elections. You know, public health is being used to undermine democracy through this toxic disinformation. Also concerned about the way in which, epidemics or pandemics can actually erode a state's capacity to act, including the cost of the pandemics to state stability and the economy. So we heard a lot about this, of course, even in the recent COVID pandemic. One of my dear colleagues, the late Drew Price-Smith, did the pivotal work on pandemics and state stability. It is a complicated relationship, but certainly it is one. And then the role of intelligence agencies in surveillance and readiness. So one recent study is a book some of you may know by Eric Dahl. It's written from an American perspective, looking at assessing U.S. intelligence failure in response to COVID. And critically, he talked a lot about focusing too much on strategic thinking around pandemics and instead encourages us to actually be more tactical, more targeted with deadlines, with clear risks, with sort of timelines, not just sort of general threats. And he argues that some of the failure was because these threats were sort of generalized. And so he makes a series of recommendations, primarily for the United States, but he does support as well the independent panel. But the role really of non-traditional security threats by U.S. intelligence needs to be strengthened, as well as the role of some of the key public health infrastructure in the U.S. A recent piece relatively recent in the Bulletin of Atomic Scientists talks about gaps in governance around biolab safety, which I know we've talked about, but specifically that there's actually a governance gap. It's fragmented and there's across regulatory, public health, and non-proliferation spaces. And so he proposes that be changed, right, with a greater resource allocation, more knowledge around biosecurity and biorisk, and careful attention to dual use technology. So you can see that this kind of goes into the intersection often with the military and strategic concerns there. The third is what I would term a human security approach, and others have as well. And this is, if number one is really a focus on health systems strengthening, and number two is really a focus on the protecting of the state, including its borders. A human security approach focuses on threats to individuals and their communities rather than simply states. And so in that context, this, many of you are quite familiar, I'm sure, with the root of this, but it really links health with poverty, violence, amongst other things. And it includes human rights, good governance. It's resonant with some of what Amartya Sen would say in terms of the capability approach to achieve your aspirations. And it really resonates with public health interests in social foundations of health and commitment of health as a human right. And so the term security within that worldview it is used by some. And it really, many of you will, of course, know the origins of this coming out of Responsibility to Protect, R2P, post-Rwanda. And it was Canadian leadership, Lloyd Axworthy, who later sort of coined the term. But then the term became broadened. And that's when really public health became a little bit more active in sort of framing in a human security approach. I think it has the potential, frankly, to link the public health and national security issues from the perspective of communities and individuals and a global health equity lens. So one scoping review on COVID-19, for example, looked at responses to global health equity and found that there was really insufficient attention during the recent pandemic of COVID, and there was unequal outcomes across G20 countries, so within even the G20. And I think we can see there's certainly been some studies here in Canada looking at postal codes, looking at the disproportionate risk that is faced by many vulnerable communities. Some of us, I think, witnessed that firsthand here in Canada. The Homeland Security report from the UNDP also talked a lot about life expectancy and health issues and their link. This was in 2022 to climate change, to conflict, to inequality, and suggests there's sort of this new cluster of threats that that links with healthcare systems struggle to respond to the pandemic and to really broke down existing healthcare systems, and then this digital technology conflict and inequality link, and it's sort of like a toxic synergy, really. And so they may propose a series of suggestions there, but at the core of it's really solidarity and collaboration on human security, the planet, and human development. Finally, in a very different sort of type of study, but some of you may know Michael Barnett's work in political science, and Michael does really, really important scholarship in international relations. And he talked about COVID-19 and what he calls the sacrificial international order. And I'll be candid, when I read this article, it kind of slayed me because it's quite rough. And he basically argues all international orders make sacrifices, and the liberal international order tends to rely on the markets to select who lives and dies. And as he says, it reinterprets those deaths then later as a form of progress. And so he uses COVID-19 as a kind of lens to challenge these assumptions. It's a very thoughtful piece, a thoughtful analysis from somebody who has done both policy work as well as a scholarship. So critics of a health security approach are not they are not happy with the term security. And there's a lot of different arguments that are made, but there are two that in my mind stand out as ones worth paying close attention to. And that is that the language of war is counterproductive to collaborative efforts. And you will see there's been a lot of conversation in the different approaches to health security about collaboration. And they're suggesting that that actually will lead to subsuming public health efforts under other political conflicts. That might happen anyway, to be candid, but it's an important caution. The other approach is perhaps even more concerning, and that is that the securitization of health language can actually compromise efforts to protect global health equity, in part because it leads to greater attention to military solutions, and it can increase the vulnerability of those who are already excluded from many of the benefits of our society. So worth keeping in mind as we move forward. All of these approaches require a global, national, and local action. They all require on some level some collaborative interdisciplinary work. And as I said at the beginning, these all address multifaceted challenges to our health systems, our social or economic, and even military intelligence systems. There are important issues under each kind of worldview. And they require these kind of complex tools of public health, social, intelligence, economic as well, I should put in there. It also requires comparative risk assessments because of this complexity. And this is where I think sometimes things can get a little bit tricky. Bioweapons are a risk, but they're a black swan as compared to prevailing risks of system readiness for pandemics, global equity, and access to care, way people's well-being is compromised, particularly when it's an acute on chronic problem. So if you have a chronic issue of social exclusion, of extreme deprivation, and then you have a crisis. And of course, we saw this with COVID, but we've seen this with multi-drug resistant TB. We've seen this with, of course, HIV/AIDS. So it's sadly, a familiar problem. I would suggest, based on my read of and listening to people, that just and effective responses require that we really do reimagine our political and social relationships to ensure that readiness and that response capacity. Eric Dahl's concept of a whole of society approach is compelling. And I think ensuring as part of that voices in defense of human rights are at the center of this conversation will start to address some concerns over this. It will also, of course, be necessary both for ethical requirements, but also and for efficacy of our system response. Aaron Wildavsky, the great political scientist from public policy, once said, policy analysis is about learning what to like. Analysis is less about the realization of preferences than about their transformation. Now, on the surface, that sounds deeply dissatisfying, but I think anybody who has ever, led policy reform processes, whether it be in an organization, in a hospital, in a public health institution, or some other government or not-for-profit or corporate institution, will all be familiar with this, the notion that you can implement ideas and you can sort of start down that process, and then suddenly you discover, oh my goodness, we're finding things we didn't know, right? And we have to adjust our expectations, our understanding of the problem, our strategy, our tactical approaches to it. Also, that sometimes our interventions sadly also create more problems, and so then we have to pivot and respond there. So that leads us into one of the big challenges in responding to these particular sets of priorities and issues. And I'm loosely putting this around governance, and there's really kind of three big ones around leadership ethics and our vulnerability in our current system. But the first is to create learning organizations. And these are organizations that are nimble, adaptable, and anticipatory. And this, we can be thinking about this at all levels. This could be in your local clinic. This could be at the WHO. It could be everywhere in between, ministries of health. I've mentioned a few possible ministries there in different governments. But I mean, candidly, education could be involved and probably should be involved in here. The finance portfolios need to be at the table sometimes for these conversations. And so it really is a sort of multidisciplinary, multi-spatial, multi-stakeholder kind of conversation. And that capacity to learn needs to be occurring in that sort of collaborative space. Critically is the ability to learn from failure, because we're going to fail, we know that, and improve our capacity to quickly adapt to new threats and changing risk calculations. And doing all of this often on the edge of or just before a crisis. Now, what do we know about that? Well, we know from our friend Michael Barnett and his colleague Martha Finnemore that this is hard. And I've got a list on the screen here of just a few areas where things can go wrong, where rules and procedures become ends in themselves. I'm sure we've all been in institutions where we've seen this happen. Universal rules are dominate and attentive or not attentive to very specific local concerns or individual needs. Dysfunctional behavior becomes normalized, or we become so isolated from the outside world that we cannot hear when our policies are failing. And then, of course, you have cultural clashes as well. So how do we break through all of that? Well, we're still learning how to learn, but there is some material out there that's helpful, and certainly some of the work from the management theorists are really good in terms of how we create institutions that are adaptive to crisis. Sim Sitkin's well-cited work in 1992, learning from small flops, as he calls it, well-planned projects that have outcomes that are uncertain, that are modest in scale, and I'll have those quick feedback loops, from the front line that help you to sort of mid-course correct. That's challenging for us when we think about health crises, right? Because often they're big flops, like we don't have that small space to learn from. And so it's worth sort of thinking if there's ways you can get out ahead of a big crisis in order to enable sort of pilot project learning in response should a crisis hit. Some of my own work is focused on practical knowledge, the role of advocates, knowledge entrepreneurs, people like Médecins Sans Frontières, which many of you be familiar with, Partners in Health, the late Dr. Paul Farmer, and of course, Dr. Jim Kim and their team. And I've written on how were able to change the World Health Organization's MDR-TB policy by relying upon those very strong community ties, solidarity with the community, and incredible dexterity in policy advocacy. And there was a real close relationship between scientific knowledge production, implementation, response to pandemics, in fact, and then realizing that they had to change policy, or they weren't the environment that they were in, they couldn't continue to accomplish what they needed to. And so then that's when they began a process of policy advocacy. And that started a process of mutual learning where they were challenged as well to respond to some big picture scale up questions that they might not have from a public health perspective had to have considered in quite the same way. So there is hope. It's possible to overcome some of these challenges. One of the big, I think, sort of if we sum it all together here is, creating these kinds of learning spaces, demonstrating solidarity with vulnerable populations with which usually they're the receiving end of failed policies, a kind of humility, frankly, interdisciplinary and pragmatic approaches, and enabling that shift from this deliberative decision-making process to, if we're dealing with a pandemic or an epidemic or health and war zones, moving into crisis decision-making. And I'm indebted to two people for this point, and one is David Fisman, actually, and also a conversation that ensued in one of my classes this past week also sort of led us a little bit towards that. And I think it's there is some work now starting to actually pay attention to that in the context of pandemics, specifically around how decision-making in a particular organization or government might change between a deliberative process and then when the crisis hit, were they able to shift into that crisis decision-making. I propose creating clearinghouse for scientific ideas and best practices might be one way for us to think about that. And it would be an inclusive kind of space. We could talk a little bit more about that later if that's of interest to people. The second challenge is addressing toxic disinformation in a post-truth culture. And, it's really, and it isn't a conspiracy theory, we really do know that there's foreign direct interference from Russia and elsewhere that are specifically designed to undermine our democracies, and they're using public health things on social media. And that's sort of aligning with an emerging far-right authoritarian politics globally. It's really challenging our kind of liberal vision of human rights and democracy. But why I put this here, not actually just simply in the national security section, which I did reference it there, is at the core of the problem is a kind of radical perspectivalism, a kind of dismissal of science, a complete rejection of any reality but one that someone defines for themselves. And so if we think about that, that means then that our societies are much more vulnerable, right? Because Social media can amplify this disinformation around public health. This shakes confidence in public health leadership and more generally in the government's leadership, and that threatens the stability of democratic order long term. And it's I was struck, I don't know if anyone followed this last week, but the Halifax Conference for Security, which is a military security conference, the topic of their discussion was democracy. And in that, they were also talking about disinformation as a public health and as a security threat. Citizen Lab here at U of T has done incredibly important work on this, and I've referenced a couple of sources here. So has another colleague who looks specifically at COVID and the way in which disinformation eroded state capacity and the social contract that we have with our governments, right, in a democratic society. So what do we do? I honestly don't know, but it seems to me that saying that public education is only part of the answer. We're going to have to get to this sort of epistemological crisis, maybe even ontological crisis at the core. Who are we? How do we know what we know? Where's the confidence in what we do here in this space right now? And how do we convey that to our society now so that there can be some repairing, perhaps, of the relationships involved in providing public health information to people? We have a huge governance gap on the social media side for regulation. So when you have that disinformation out there, anyone who's been on social media is sorely aware of this. And it, as I said, it is an existential threat to our democracies. Third and finally, aligning our pandemic response, our public health responses more generally with moral imperatives. And I see this in sort of two spaces. One has to do with the health equity, the global health equity, bolstering our national structures of funding and policy deliberation that create space for the most vulnerable at the center. Prioritizing delivery science here might be useful. Some of you may be familiar with this article by Jim Kim and company in 2013, but it's actually something that WHO has been watching very closely. And they said that to me, that they're watching they said, we're watching the team from Harvard and their delivery science work. And it really seeks to sort of bring all of these things together in pragmatic design of programs and the delivery of programs, both the policy, the public health, the clinic, the ethical imperative, and it's like so more of a diagonal, not a vertical or a horizontal approach. The second area I would just think that we have to be thinking about carefully is preventing government overreach in surveillance, containment, and emergency powers. And this is tricky, right? I mean, how do you create spaces for deliberation that balances, on how we can balance civil liberty and yet public safety? Right. And there's long histories of governments coming in and saying, no, actually, you will be vaccinated or we will have quarantine and that. And so those conversations about how that is interpreted now against the backdrop of point number 2 is going to be, I think, quite important. And one of the ways is to protect an independent judiciary as well and due process at the core. So there's a lot here. And I think it when I was reasoning through what to share with you today, I couldn't get past this epitaph that was on William Wilberforce's, I'll put it back here, on his grave in Westminster Abbey. And he and a whole colleague group of activists, of course, were involved in the abolition of the transatlantic slave trade. But in an age of good and in an age and country fertile and great and good men, he was among the foremost who fixed the character of their times. And I thought about this in the context, it does come down to our values, it comes down to character, it comes down to principles and how we think about these challenges. And I thought I would be remiss if I didn't actually put that out here. I couldn't get this shape the character of their times out of my head, because if we look at the battle that we're in right now, candidly, there are some great and good people doing really honorable work, and many, I'm sure, around this table. And but we're fighting against some people who would say that lives are expendable and that they can be traded off, and that democracy and authority is going, and authoritarianism is the way to go, and so we're in a bit of a fight. And I guess I would just say, may it be said of us that as we think about health security, that we be amongst the people amongst the good people who are seeking to fix the character of our times. So with that, I think I'm close to my time here. And I think if I'm correct on this, my clock going here. So I'm looking forward to the comments. I've put some sources at the back. This is not comprehensive by any means, but I just thought it would be useful for people if they were interested in looking at some of the sources. So thank you all, and I look forward to a great discussion.
Thank you very much, Sure. I think it is a super helpful overview. You have described 3 approaches: the public health approach, national security, and human security approaches, which could be broader than just biosecurity or biosafety. And you have talked about how we can overcome some of the barriers and create learning organizations and more. And that's a lot. And I think that this will help us to generate some great discussions. So let me take this time to introduce our panelists, Professor David Fisman and David Haldane. David is an infectious disease physician and epidemiologist and a professor at U of T, the Lana School of Public Health. His interests include using data sets as epidemiological resources, mathematical modeling and simulation, decision cost-effectiveness analysis, infectious disease and climate change, as well as, of course, health security. He has published extensively on pandemics and epidemics and emphasizing on readiness, prevention, and control. He is a fellow of the College of Physicians of Philadelphia and the Canadian Academy of Health Sciences and remains an active clinician. Victoria Haldane, our faculty at Dalla, is a global health systems, services, and policy researcher with an interest in participatory implementation science, health systems resilience, health security, and strategic public health approach. She has worked with leading organizations, including WHO, World Bank, PHAC, and the Independent Panel for Pandemic Preparedness and Response. She is currently a member of the Scientific Coordinating Group for the National University of Singapore Lancet Prime Commission, leading work to develop grassroots indicators of pandemic preparedness. She is also a member of the founding steering committee of the Pandemic Evidence Collaboration, which is an international research network, which aims to identify, develop, and implement strategies to generate high quality and actionable evidence on non-pharmacological interventions during pandemics. So may I invite our panelists, David, to Victoria, to respond and share their thoughts on health security.
Sure. Do you want to go first?
You can go ahead, David. Up to you.
All right. I don't have a ton to say. I mean, that's just a great presentation, and I love the almost implicit Venn diagram there in terms of the different elements of health security and a pandemic response. I think that's very astute. I guess I can or maybe I won't do this up front. Maybe we'll see if it comes up. I was thinking I could talk about my top 10 favorite lists of ways in which we didn't quite get the job done in the pandemic here in Ontario. But I think maybe I'll just start off by restating what I think one of the critical additional issues is, and that's a clear and honest statement of values. And I think that's really tricky because people say things publicly and then their actions sometimes don't match up with their words. I mean, what I think there was early sloganeering in the pandemic about how we're all in it together. I think that's implicit in some of the more health and human rights based approaches to pandemic responses, is that everybody is valuable, but then we responded in ways that really ensured the health and well-being of more affluent individuals in our society and ensured that less affluent and less resourced individuals just, pardon my language, just got the hell back to work without protections that we could have given them. For example, the knowledge was there as of March 2020 that this was an airborne pandemic. Action was not taken in Ontario, was not taken pretty much anywhere that I'm aware of to ensure people's safety and security based on that. So I think when you're saying one thing publicly and then you have actions that not only appear to be in contrast with that, but actually have very measurable real-world impacts on disadvantaged populations. I referred, when we talked beforehand, to the fact that here in Canada, we know that your relative risk of dying of COVID during the pandemic, if you were both Black and poor in Canada, was fivefold. So you had a 400% increased risk of death in Canada if you were both Black and poor. That says a lot about us and about how we responded, because differential risk in different groups was the product of our action, and we acted in ways that protected some groups and didn't protect other groups. So I don't know what the answer is. Politicians gonna politician, right? So in terms of expecting politicians to be completely honest, transparent, there's a tension there for them, because if you're honest and transparent, you're not a politician after the next election. You have to find a new job. So that's very challenging. I think there's also some aiding and abetting that goes on from within academia. One politician who I like very much said to me at one point during the pandemic, one of the difficulties for us is that we can pick and choose and get the expert whose opinion aligns with what we want to do. So I think there was a lot of decision-based evidence making that went on during the pandemic. And I think the academic community has to look itself in the mirror a little bit around some of the bad guidance that happened. And maybe I'll leave it at that.
And I can pick up on some of the threads that David was just weaving and drawing on, Joy, just in terms of equity and community trust as a principle of what we're doing and not an afterthought, something that is by design and implementable. And especially if we're looking towards other threats on the horizon, other health system shocks, moving beyond the pandemic, we have a foundation of low trust, and we have a very recent history of a lot of complex and many missteps when it comes to equity and equity deserving communities in Canada. And I think if we're looking towards threats on the horizon and we want to take this futures thinking approach to health security in Canada, and what are the complex threats facing us in the next 10, 20, 30 years, we have to realize where our starting point is, and some of the harms that were done during the pandemic, and some of the work we have to do to rebuild that trust, to rebuild that community perspective, and to have it be foundational to the work we do to advance health security in Canada. And that kind of our definition of health security in Canada really has to acknowledge where we've come from and where we want to head, and bring in those human rights perspectives that Joy brought up, and really walk the talk when it comes to this in communities. So I think both points by David and Joy were really well made.
Joy, do you want to respond to the comments?
Yes, thank you. And I very much appreciate both of them. And it resonates with what I've heard from my corner and what I observed, certainly from the pandemic here in Ontario, but also when we look globally, right? I mean, just the systematic decision to, I'm sorry, hoard vaccines. I understand why the decision was made, okay? But what I'm saying is that globally, when there were health workers that were in, certain very vulnerable communities internationally who didn't have access to masks and didn't have access to vaccination, right? And, what I was hearing from my colleagues on the ground was just beyond disturbing. And so if we are going to talk the language of global health equity and national health equity, I agree with you, David and Victoria, we've got to live it. And we've got to, first of all, acknowledge what we've done wrong and turn away from it. We have to say, that this is where things have gone wrong. And, then concretely build this in. And I think that's why I was really feeling that this needs to be at the center of the conversations, not sort of put in on the sidelines. And, David, your point about politicians are going to politician, a politic, absolutely. And I think it comes out in Eric's book as well, when he starts talking about how do you get people's attention in government, and there's, you're sitting there. I think it was Barack Obama who said, by the time someone comes to you as president, with a problem, everybody else who's super smart has said, I don't really know how to solve it, or they've come up with ideas that aren't plausible, and it's up to you to make the call. And even when someone is well-intentioned, it's problematic because they have these competing claims. Never mind if people are more complex, shall we say, than that. And so I think one of the questions for me that comes up as a political scientist is, who are those individuals who've been very successful in actually holding governments into a place where they can to account when it comes to issues of global health equity or health equity human rights? And I obviously did my research on one of those groups, Partners in Health and MSF. And you're not always successful, right? Like that's the thing, those efforts at advocacy are very slow and painful. But we do know a lot about that in political science, about some of the things that can be helpful. I think that for me, the tough part is what I'm hearing echoing in both of your comments, which is that that's like a never-ending cycle. Like you can't just sort of say, I got that policy changed and then that's done. And, because that might just be one part of a larger problem of health equity, which could relate to education and all of these other social foundations of health, access to food, shelter, safe homes, all of those things. And the way in which race intersects with all of that, again, has also not had been adequately responded to from the design stage of some of our initiatives. So it's almost like it's a never-ending effort, and that's the hard. You're in it for a long walk, and if we let up, then those things, it's not guaranteed, right? The progress rolls back.
I'm looking at the Q&A box, and there are a few questions coming in. I won't be able to read out all the questions, but I'll try to summarize for the speaking panelists. One question is related to Joy's mentioning of creating learning organizations. And so what are the practical activities that we can actually do to create learning organizations for health security, and that can uphold global health equity? And the other question, again, addressed to both Joy and panelists, is can you explain a little bit more about the scientist clearinghouse idea? So in relation to your presentation.
Yeah.
Joy, Victoria, David. Yeah.
They're actually sort of, those two questions I think are nicely related. We do have quite a bit of material on creating kind of knowledge spaces or knowledge networks, and thinking about organizations from the vantage point of intersectional networks or partnerships. It can be somewhat useful, I think, in this particular case because of the nature of the problems. And so, imagining, for example, maybe it's a place like the Institute that can be sort of a central place where these conversations can take place, because you don't actually have, it's hard to find a place where you can actually have all of these different viewpoints in a room having the discussion about what are the scientific best practices on these, what are the best concrete strategies, right? And then with close ties to practitioners, close ties to those on the implementation end, so that you have a feedback loop that comes back to scholars who are analyzing these things, and including policy members of, whether it's PHAC, whether it's WHO, have them in on these conversations, right? And other departments as well as relevant. And so that requires a kind of broad strategic perspective of an organization to sort of say, these are like the priorities. This is like the conceptual, the scientific research through to the implementation. And what do we know about implementation science on this? So, some of our colleagues do some amazing work on, and David, you've been part of these projects. I know, Victoria, you as well, in terms of how, what happens when you try to deliver, right? In the sense, and I'm thinking of even people like Trish Greenlaw, who does some really fascinating stuff on where things go off the rails, right? Bring those discussions to the center, and create an institution that actually can both look at best practices, but then can be involved in implementation itself, which public health, does lend to that, right? In the sense that we have close ties with those agencies that are implementing, and not-for-profit organizations as well. So, the clearinghouse sort of zone is kind of like a global, sort of like a network, a knowledge network. And we've done this at U of T before, by the way. So I was part of a project years ago. We have had 4 really important networks at U of T, all in science. One using science to promote peace building in the Middle East. Another one, the world's largest urban planning network, was based here at U of T. And it brought together practitioners and scholars, and it was called GURI. And I'm not sure if it's still going. Big funding, really interesting work, and implementation. So I guess and I'll stop because I don't want to dominate this conversation, but I think the only other thing I would say is pay really close attention to some of the work coming out of management. There's some really good scholars around in management doing organizational learning and the sort of adaptable mid-course correction. So SimSitkin is one. And there's a few scholars that are doing work that looks at the intersection of justice and equity and organizations as well. And so I think that though I don't know if I've adequately answered that question, but that's sort of where I would start.
And I can hop in and kind of build on that with some of the work we've been doing. And this is all from my own interest, as well as I'm really interested in strategic foresight for public health and health security, and taking that futures looking lens and applying it onto this cycle that, we see in policy labs of getting together, bringing groups together to work on policy problems, come up with solutions, workshop things, create that space. But I think a missing piece we often see is this, that's so important in health security, is this idea of strategic foresight, this idea of looking to the future, of applying futures thinking, of identifying those threats on the horizon that not only are these shock events, but that multiply the existing crisis we already have that are straining our systems. So using foresight from a very public health approach, from a health systems approach, and from an equity approach. So exploring how these different scenarios affect populations differently, how our preparedness and response strategies might reinforce discrimination, having those voices at the table from this plausible futures making point through to the scenarios or the ideas that we're workshopping, that we're testing, and bringing in that kind of tabletop exercise point of view where we're actually running through things, working it through. Sometimes it sounds glib that you're just, a bunch of guys and girls around a table talking, bogsat is what they call it. But when you have some structure, when you have some foresight that's informing that, when you're thinking very creatively and critically about the future and about the capacities we have at hand, the crises we have at hand, it can be a really powerful space for conversation. And in my experience, being in these sort of exercises, the values piece starts to come up while people are focused on the task at hand. And it can help us get to those places of organizational values, of broader values. And it's just a practical strategy and a layer that we can put on top of these approaches within learning organizations. And we know it can be done. We've done it here in Canada. Recently, we've done some work on exploring health system preparedness and resilience for mass casualty repatriation from a hypothetical theater of war overseas, but intersecting that sort of conflict-driven crisis with a pandemic, with cyber attacks on key infrastructure, with climate change events, because we know the future shocks in Canada are going to be multiple, are going to be complex, and we just need to start creating those spaces where, we can start to work some of this out. So I completely agree with Joy.
David, do you have any thoughts?
No, I don't think on this. I think I don't have a lot to add to that. That's very well said.
Thank you. So there's another question in relation to the COVID pandemic, because Canada actually had achieved a lot. We've got high vaccination rates, low infection rates, and death rates compared with other countries. Still a lot of lessons that we have learned, that are structures that we've built. So how do you think that these lessons and structures can help us navigate the next public health crisis, non-infectious or infectious in nature, and what are the things that we should be keeping in place in relation to health security? Another related question is there's a lot of distrust to the scientific community, including to virology research, for example. It's a concern of lab leak, and there's a lot of distrust. So how do you handle that? What are the things that we should be keeping, and how do we rebuild public trust? Call upon David. Maybe you can go.
Sure. I mean, we've kept very little. We've disbanded leadership tables. We've radically downsized efforts around things like wastewater surveillance. In Ontario, we haven't taken advantage of emerging technologies. I was talking recently to someone from Chicago Public Health that is now doing airborne surveillance in public places for a variety of viruses, including H5 flu and COVID. And parenthetically, there's never not COVID in the air. They're doing the airports, a couple of Sentinel cafes, and so on and so forth. So there was a lot we could have built on. But I think that the impulse has really been to not talk about this, because it was a trauma for everyone. I think it was a trauma for politicians. I think politicians have the sense that they're damned whatever they say, which is probably true. And so I think there's just this desire to turn the corner on this. I will say, related to the trauma, I mean, I don't know how many thousand hours I put in working gratis around the Ontario and Canadian public health response. I did a Canada COVID report every day for about, I don't know, 2.5 years or something. And I felt that the reward I got for that was very much not having my institution have my back when people attacked me. So I think something else you have to think about in terms of next time is if you don't actually support people who know what they're talking about, and you leave them to sort of take incoming fire without support. And this is, I mean, I'm going to explicitly call out University of Toronto here. It's a great place to work in a lot of ways, but during the pandemic, there were things they could have done to help and protect some of us that they didn't do. You can't expect people to show up next time, right? In terms of trust, I think a lot of the mistrust stuff comes from misinformation, disinformation is very well crafted on social media. I don't want to get into the issue of lab origins because I think we just don't know. And I suspect I differ from Samira Mubareka, put that question up in terms of how much uncertainty there is around that. But that's a great example of where we haven't really done the post hoc kind of post-mortem and figured out, what do we know? What will we probably never know about origins? Similarly, we never had a COVID inquiry in Canada. Other countries have had them. The UK had one. And it was excruciating for some of the public health officials involved and some of the politicians involved because they talked about how poorly made some of these decisions were and how poorly they responded to changes in information, especially around things like airborne transmission of COVID. So if we're not going to, I think the independent panels, they're great people, but I don't think they're independent. I mean, the Canadian Independent Panel are folks who are kind of very much the outsiders who are on the inside with Public Health Agency of Canada. And I don't think you've really had an arm's length attempt to do a post-mortem on the pandemic. And I don't think you've done a good job of convincing folks who have skills and expertise that they should go through this again next time, as opposed to just, spend their time at home baking sourdough bread. If that's, if that makes sense.
I would just add, if I may, David, because you did what you did during the pandemic, I was able to keep my 88-year-old father comparatively safe. And so I think there's a lot of, and you and Tara Moriarty too, with her work on the wastewater, and people like myself who didn't quite know exactly where to look, and was sort of looking in a lot of different places, and ended up being really surprised at the end at who, by and large, were calling things accurately over the trajectory. And I was able to rely on what you said, and that was really did help me take precautions. So I want to thank you for that.
Thanks for saying that. That's very kind.
Well, because of the interest of time, I don't think that we can answer all the questions that has been sent to us. But what I can see from the question is that there is a lot of disciplines who really thinks that they should be engaged in the present and also future conversations, acknowledge each other's expertise and how to create a space that we can continue to discuss these issues moving forward. My final question to Joy, as our guest speaker, is that our institute is actually prioritizing work on health security in the coming years. And what do you think that we should be doing? What should be our next steps as an academic platform? Because as you can see, there's a lot of interest from different sectors, different disciplines, and we're really hoping to move this conversation forward. On the heel of Joy.
Thank you. Well, it would seem that maybe first starting with a discussion about what we think the top priority should be in concrete terms. I think in this space, what's rising to the top is equity at a center and dealing with histories of structural violence essentially against vulnerable populations. And so putting that topic at the center might be one of the critical first steps, but also, larger the resilience of the health systems. And, David, the comments you've made about, and these things aren't mutually exclusive, of course, but, what we've done, what we did well, and then where we dropped the ball in Canada, and, what's been undone, and how do we then think about putting that forward as a priority in our own political space and internationally as well. Those might be two big areas of focus, and there are others, but sitting down and kind of coming up with sort of a consensus around what we would want to then be working on. And then bringing those individuals to the table, being quite mindful that different disciplines are going to be probably working on this and framing it in very different ways. And we're going to have to actually learn how to speak each other's languages and hear each other. And I think that's central as well in terms of creating a momentum I noticed one of the questions referenced authoritarianism, and I resonate with that question quite strongly. But I think that by building capacity here, this can be one of the actions. We can take advantage, frankly, of the fact that people are becoming aware of some of the risks, and that we could be an agent in a positive way for fighting against a sort of an anti-science authoritarian agenda. So bringing, practitioners, NGO workers, scholars, scientists, and government representatives from multiple levels. And I think making that tractable is going to be hard, right? Having really targeted strategic questions and conversations. But if we could sort of start that and get the agenda and get some of the right people at the table. Quite often, sometimes we get the wrong people at the table. I just want to flag that. I saw that in the international space, where sometimes the wrong people were at the table. And so making sure that the people who are really working with on the front lines of vulnerable populations are there and can really highlight what we've missed, frankly, particularly as scholars. That would be where I would start. If you see yourself as a knowledge network, that kind of vibe. There's lots of material too in terms of how you can make that work. I think people will have different perspectives, so some conflict resolution skills in there is also going to be important.
And also, I want to add the equity deserving communities. That should be conversation as indicated in one of our questions. So that's really helpful. Well, thank you, Joy, and Victoria and David, for your time and sharing your insights on this really important topic. We do want to follow up with a survey after this webinar. Maybe Ted, you can tell us a little bit more about that.
Yeah, for sure. So there's definitely a lot of engagement, a lot of interest in this area, and health security is one of our priorities. So we would like to bring people together who are interested in working with us on this topic. So there is a link in the chat, and we'll send it after the webinar as well. So we encourage you to complete the quick survey and just give us information about you and what you would like to work on, and then we'll be in touch with everybody in the next few weeks or so.
Fantastic. Well, thanks again. It's a wonderful, wonderful discussion. So here I would like to end, thank all the speakers and panelists, and also the questions that's being generated during this Q&A session. So with that, I'll close this webinar. Thank you very much for attending.